Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Muhamad Aly Rifai, psychiatrist, internist, and addiction medicine specialist. Today's Kevin MD article is It's Time to Operationalize Physician Wellness. Muhamad, welcome back to the show.
Thank you for having me to talk about this timely and important topic on physician wellness and how we can make help for our colleague physicians more practical and to operationalize that process for healthcare systems as well as practices around the country.
All right, so tell us what this article is about.
So, in the article, I write as a physician who has been involved for as many as 20 years with my state's physician health program, which basically caters to physicians who are impaired, whether with psychiatric illness or whether with drug and alcohol and substance use issues. And in that experience, I've been blessed to be able to have helped a lot of colleague physicians, but I've also have seen a lot of colleague physicians who have just flickered away in terms of succumbing to their psychiatric illness, succumbing to their drug and alcohol issues, leaving the field of medicine. And we're also seeing that it's not just that. We are seeing that there is a significant amount of burnout. And we are seeing that physicians are leaving medicine in droves. You have post after post on your blog showing that that's a significant problem. We've also written about how physicians are overrepresented with depression, anxiety, post-traumatic stress disorder, and how suicide in physicians is also significant. We lose almost one medical school class every year to suicide, and September is Suicide Prevention Month, is Depression Prevention Month. So I think it is time for us to talk about how do we take practical steps. We're just talking about this as a phenomenon and not offering any solutions. So I try to just present some practical solutions where we can talk about that and we can kind of give a message to health systems, to hospitals, to clinics about how to really operationalize physician wellness in a way where we could ensure that physicians show up to work clear. They're feeling that they're able to help their patients. They're not feeling that they're burdened with electronic medical records, with paperwork, with patient issues, and that they're able to listen to their patients and not go home and find out that they have an additional 2 or 3 hours of work and develop depression, anxiety, post-traumatic stress disorder, and leave medicine and, God forbid, have suicidal thoughts. So I think some practical steps are very, very important, and I offer in the article some of those practical steps.
All right. So before talking about some of these solutions, we've been talking about burnout, like you said, for many, many years now. Do you feel that hospitals and medical institutions are taking it seriously? And are they making progress in terms of operationalizing physician wellness? Like, how far have we come?
I talk in the article about that. I talk about some organizations that have taken it seriously, and they have taken some that playbook and really started understanding what's going on with their physician workforce. They try to deploy some of these strategies that I recommend, and these organizations that have been moving have been able to actually retain clinicians, have better outcomes for their patients, have better satisfaction scores from their physicians, their providers. They've been able to reduce errors, and they've been able to build a reputation that there are a place that honor that concept of basically trying to reduce burnout in physicians and providers, and that they're able to exert excellence and show humanity when they're dealing with their fellow physicians and their employees, and that these things are non-negotiable, that they really need to hone in on that. But there have been organizations that just didn't are not heeding those warnings, and they continue to bleed talent and trust. So we're really seeing that some organizations are really honoring this, and there's now really you can see which organization is valuing physician wellness and some organizations that are not valuing that, and they're bleeding talent and they're bleeding trust.
All right. So let's talk about some of the solutions that you mentioned in the article. Where do we start?
So You start at the top. I mean, I don't think it's a solution that starts from the bottom. You need to start at the top. The leadership needs to be involved. The leadership needs to sign on to that. And they need to basically be a role model for that. They need to show humility. They need to basically understand that showing humanity, whether a person has burnout, has issues, they need to model vulnerability. And so, for example, we talked in the past about even in government agencies that are related to health, like, for example, Secretary for Health and Human Services talks openly about his depression and about his history of drug use issues and how he was able to work through that and how he continues to struggle with that. So leaders who tell the truth kind of and show vulnerability, they will show basically as a role model to their fellow physicians, to the people that they supervise, that basically they're really meaning changes and that they really presenting these kind of this visibility, and they're
Mhm.
able to provide that example to other fellow physicians that it's okay to seek help. You're not going to be penalized if you seek help, and that is an avenue to reducing errors, better patient safety, better productivity, and mostly basically the organization would be more profitable if their physicians are happy, patients are listened to, there's reduction in error, and there's improvement in productivity.
There's some steps in your article: structured, trained peer support programs, changes in credentialing, licensing. So go on in terms of next steps after that person on the top understands the burnout plight.
So I talked about the fact that there needs to be wellness committees, and those have been evidence based, and they've been shown to work. Basically, if the leadership involves the second tier and third tier and even the fourth tier physician colleagues in groups of wellness groups that focuses and provides suggestions to the leadership about what is it that we can do to improve the lives of physicians, to improve their productivity, to reduce error, to reduce depression and anxiety. That shows that there is significant input and there is feedback from the common
Mhm.
physicians to the leadership. There's also I talk specifically about the issue of confidentiality and the issue of credentialing and how on every medical staff applications there's questions. Have you ever suffered from depression and anxiety, mental illness, drug and alcohol issues? And those ever, and the questions are ever, and so that actually, if somebody had ever had an episode of depression or grief many years ago, they still have to declare it, and they would have to be questioned, and they may have to be referred to a psychiatrist that would clear them to ensure that they're not experiencing any current issues. So, reviewing those credentialing applications, basically legitimizing that it's okay if somebody has issues
Mhm.
and seeks help, as well as protecting time for individuals to seek help and to be protected. State medical boards continue. I know my state medical board, the state medical board next door to me, they continue to ask about drug and alcohol use. They continue to ask about depression, impairment. Now there are in states where medical marijuana is legalized, physicians have to have the option to invoke their Fifth Amendment to talk. If they've ever used marijuana, they have to invoke the Fifth Amendment to basically get away from the question of whether they've used marijuana, even though it's legalized in their
Mhm.
state. So confidentiality and understanding individuals' issues with depression and anxiety continues to be a problem, and the leadership, I think, can work on that and can really manage that significant change.
So if we know that when state medical boards and credentialing committees keep asking about behavioral health issues, that creates that stigma surrounding behavioral health in physicians, why can't they just take that off the forms? What's the argument on their behalf?
It's an incremental change. I mean, they argue their default position is, oh, it's patient safety. We don't want somebody who has depression to be managing patients. But there's really no clear evidence to suggest that if somebody has depression or anxiety, that they're going to be a physician or a provider with poorer outcomes or with errors. In fact, actually, there is significant evidence that if you have those conditions, that you may be a more compassionate physician, that your outcomes may be better, that you probably less prone to errors because you put yourself in a patient's shoes and you understand that what they're going through. So there is basically it's stigma that is prevailing and that's persistent, and it's going to take more and more time. I mean, hospitals credentialing applications just take so much long time to change. State medical boards is the same thing. So once these things seep into these applications, they're very, very hard to take away. So I think that's where just these entrenched positions about not catering to physician wellness, and only those hospitals that will tend to these issues, that will show more credibility, and they will be able to retain more talent and be show that they have more human atmosphere of practice of medicine in their institution.
To your knowledge, are you aware of any hospitals or state medical boards who've removed those questions?
Yes, yes. So they are hospitals that are removing those questions. I've consulted with a couple of hospitals that actually removed these questions away from their credentialing applications. And they actually just default to the best judgment of the physician, that if they have anything to declare in terms of their health issues, so they frame it in general health. Is there anything in your health history that you would wish to declare to us on a voluntary basis? And actually, some physicians may declare that if they feel that they need special allowance for specific times or appointments or things like that. So it becomes actually more of a voluntary rather than a mandatory disclosure. And the physician feels less stigmatized, and they feel that they're able to disclose that to their workplace because the workplace will gain a better understanding of the things that they struggle with and could be more passionate, and the person could be more productive in terms of their patient care.
Now, you mentioned that there are hospital systems that take burnout seriously, and that leads to better morale, better retention, even increased revenues. Can you share a particular story where a medical institution has changed their stance towards the better and it really made that appreciable difference in the physician workforce? Just tell us a story so we can visualize what that would look like.
Sure, absolutely. So a large hospital system that had about 13, 14 hospitals experienced several incidents where there was physician suicide, completed suicide by physicians. And so that kind of rang a five alarm, basically fire in the leadership to understand what has happened and to do a root cause analysis. And I was involved with that. And basically, one of the things was that the medical staff application was involved, and that some of these physicians actually did not disclose these informations. The physicians that ended up unfortunately committing suicide did not disclose any of that information. And basically, the decision was to remove those items and make them voluntary, not mandatory.
Mhm.
And over the next 2 or 3 years, people saw that physicians sought more help. They've also established, and I talk in my article about that, they establish an outside counseling firm with psychiatrists that are not in house. Because physicians, when they seek help in house and they're referred to an in house psychiatrist, they fear that their medical record are going to be open. People are going to see, oh, this person is seeking help for depression and anxiety. So seeking help outside the system. And I'm the psychiatrist for that health system. They refer their physicians, their employees for me to see, because basically they value that they're able to provide their employees and their physicians with outside help, and they feel much more appreciated.
Mhm.
They feel that their privacy is protected, and they feel that actually that the health system is invested in their wellness and in their improvement, and that there's actually no prejudice and no stigma about them seeking help, psychiatric help, because it's completely confidential, and they've had increased outcomes, they have reduction in error, and they had increased profitability. So it can be done, and it has to come from the leadership.
We're talking to Muhamad Aly Rifai, psychiatrist, internist, and addiction medicine specialist. Today's Kevin MD article is It's Time to Operationalize Physician Wellness. Muhammad, let's end with some take home messages that you want to leave with the Kevin MD audience.
Sure, sure. I believe in medicine that we can focus on the human that is inside the white coat. A physician who is cared for will show up with clearer mindset. They will listen deeper to their patients. They will think more precisely, and patients will feel it. Safety data will reflect it, and retention curves will confirm it. And basically, this is the future. So if we have physicians who are struggling, we're not going to have good outcomes. If you are a physician leader, you need to operationalize this change. If you are a physician, you need to ask your people to follow, and patients will benefit, the culture will transform, and we can build a profession where it's safe to talk about your own vulnerability, your own illness, and that will make you a better physician, and that will make you a better provider for your patients.
Muhammad, thank you so much again for sharing your perspective and insight. Thanks again for coming back on the show.
My pleasure.